With us today is Dr. George Bakris from the University of Chicago. Hi, Dr. Bakris.
Hi.
Can you tell us a little bit about the emerging opportunities for the treatment of hyperkalemia?
So there are a number of emerging opportunities for treatment of hyperkalemia, not only in heart failure, but across the spectrum of people with chronic kidney disease, defined as an estimated GFR of less than 60. And certainly heart failure patients have a very high propensity to be in that category with kidney disease on board, either from diabetes or long-standing hypertension or some related cause, usually to the heart failure itself. So who is at risk, first of all, for developing hyperkalemia? It's not everybody. It's people with an estimated GFR of 45 or less, and people with a potassium level, serum potassium, of greater than 4.5 who are already receiving a diuretic. So if you're in that category of someone who's on a diuretic, especially a loop diuretic, and they have a potassium of greater than 4.5 and their GFR is less than 45, then they are at the highest risk for developing hyperkalemia, assuming that you're going to give them either spironolactone or eplerenone or even a higher dose of an ACE or an ARB. So that's really the group we're talking about. And, of course, heart failure patients, many of them fit right into that category. And that actually turns out to be a limiting factor in available therapies that we know reduce mortality and, for that matter, reduce morbidity in heart failure. And specifically, I'm talking about use of mineralocorticoid antagonists. So I think really the emerging opportunities, all we've had so far for this is K-exalate. K-exalate is a sodium-based binding resin that has a tremendous side effect profile, especially related not only to constipation, which is generally severe, but also intestinal necrosis. And initially that was thought to be due to sorbitol, but now it's been well documented that it's actually the K-exalate crystals that contribute to this. So people were very reticent to use it, and as a result, many patients who could get a benefit from these agents based on the trials were unable to get them. Now we have two new agents, patiromer and probably soon to be approved, ZS9. Patiromer is already approved. It was approved in October of last year and is a calcium-based resin that is far better tolerated than K-exalate. In fact, there are data from a one-year follow-up trial that we did, and that was published in the JAMA last year, that shows the tolerability of patiromer at various doses in people with advanced kidney disease. And so that is available right now, and it's a once-daily dosing. And then the ZS9 is a sodium-based, not a polymer. It's a different kind of lattice molecule that also binds potassium. Of course, all of these are in the distal colon, is where their major mechanism is. And the difference is that the 9 compound has a base that is very sodium avid, and as a result will require a lot of fluid intake when you first start taking it. In fact, it requires 750 cc's of water when you first start taking it. Patiromer is about 60 cc's. You don't really need more than that to ingest it. And again, constipation is the most common side effect seen with patiromer. And the ZS9 compound has edema as one of its major side effects. So in heart failure, certainly the ZS9, if it is approved, which is supposed to happen in May or June of this year, may be a bit of a limiting factor because of this edema. And the patiromer is, in the studies, we gave it with all the medicines, but there's some concern at the level of the FDA because in vitro studies show that it binds some drugs. So they want to leave 2 to 4 hours in between other medicines for you to take that. And that is actually still under discussion and evolving. So those medicines are available. Those medicines are going to be facilitators of agents such as spironolactone and naplerenone in heart failure, and for that matter, even higher dosing of ACE inhibitors, because the potassium rise that those normally cause, which is anywhere from 0.4 to 0.8 milliequivalents, will be mitigated by these agents and the binding in the gut. So clearly, we will now be able to test some hypotheses that we couldn't test before, specifically people who are prone to hyperkalemia, usually with worse renal function than the other group, will they still get the same benefits as the groups that have already been studied that hyperkalemia was not a problem in? So all of this is evolving. All of this is in the forefront here, and hopefully within the next 3 to 5 to 6 years, we'll have some meaningful data in these areas and be able to answer these questions.
Can you explain to us a little more in depth about the pathophysiology and mechanisms of action of some of these new potassium binders?
Sure. So, first of all, some general concepts. 90% of the body's potassium is handled by the kidney, 10% by the gut. That's under normal circumstances. As you lose kidney function, and in fact when you get down to levels below 45 mLs per minute of GFR, the gut starts handling more potassium. And in fact, in dialysis patients, the gut handles 20 to 25% of the potassium in the body, since the kidney can't handle any of it. Now, where is that handled in the kidney? And that's through potassium secretion in the distal colon. So when you're ingesting oral medications, assuming normal transit times, it's not going to happen. You're not going to get an acute effect. You're not going to get an effect in 1 hour or 2 hours. You may start getting a little bit of an effect, but the effect really is seen, for all intents and purposes, after about 6 to 8 hours. And the reason it takes that long is it takes that long for the substance to get to the distal colon. So I think that's, first and foremost, these agents are not meant to be used for acute management. They're meant to be used for chronic maintenance therapy to prevent elevations in hyperkalemia, elevations in potassium. So I think in that regard, when you look at the mechanisms of how they work, they affect potassium secretion, and basically that secretion of potassium is binding all the potassium that comes out. And in fact, these molecules are saturated enough that in the case of pathophysiology, it actually may bind, because it's a calcium-based binder, it may actually bind a little bit of magnesium. And there are very small reductions in magnesium seen with pathophysiology. We're talking about an average of 0.05 milliequivalent reductions with magnesium. And so clearly this is an issue that does have to be monitored to a certain extent. The interesting thing is the ZS9 compound. Actually, the makers are trying to tout that it has an acute effect. And it's interesting because the chemistry of the molecule doesn't really have an acute binding effect, but what it does have is its effect on changing of acid-base balance. And within a couple of hours of ingestion of the molecule, it releases ammonium ion and actually makes the milieu more alkalotic. And as a result of being more alkalotic, you change the pH. When you change the pH, potassium goes into the cells as pH goes up. So you actually are causing a shift of potassium into cells, and it's not binding anything. It's simply doing what glucose and insulin would do under normal circumstances in the upper gut. And by the time that effect wears off, the substance has moved down into the colon and is actually functioning the way it normally would after about 6 to 8 hours. So I think it's important to understand that the chemistry of these molecules is different. The effect is essentially the same. They're both well tolerated, and they both work in the distal colon to affect potassium secretion.
Are there any takeaway points or messages that we should take with all of this?
Well, I think the major takeaway points are, number one, we now have one clear binder that is well tolerated, safe, and can be used in people at risk for hyperkalemia, especially who are undertreated based on current guidelines. Hopefully there will soon be 2 such compounds by the end of the year, and so physicians will have an option to evaluate both compounds and see which one suits them better. Obviously, in the heart failure arena, the one that is sodium-containing may have some limitations, especially in people already prone to edema, but I think it remains to be seen what each compound brings to the table. And so the other good news here is that at least the compound that is already out in the market, that is patiromer, is available to patients with insurance for a cost of $20 a month. So it's very, very reasonably priced. And I say that because the recommended price is $650 a month. So the manufacturers have made them very appealing so that they can get used, get experience, and go from there.
Thank you for your time, Dr. Bakris.
No problem. Thank you.